going to focus on arrhythmias because that's my area of interest, although I will touch on some other cardiovascular medicines that you will frequently see and perhaps need to use in these patients who are pregnant. As patients are getting pregnant older, you're going to see people who have other diseases besides being totally normal hearts. So that said, management approach to these patients is similar to those who are not pregnant, although there are several unique considerations, and we've already sort of touched on those, but you have to worry about the effects of the drugs, any drugs you use on, or whatever you're going to do on the unborn child. This is what makes people very nervous. There are characteristic changes in drug absorption and metabolism, but pregnancy, the different stages of pregnancy make the drug absorption and metabolism so different at different stages that it's hard to predict what's going to happen with any given drug. There are also characteristic hemodynamic changes seen in pregnant women, and I'll go over those. This is a schematic that I had drawn for a book chapter that I wrote on this, but it outlines all of the changes that we see. It's not important to sort of memorize everything that happens, it's just important to know that a lot is going on in pregnancy. There's increased cardiac output, so there's increased renal blood flow and excretion. There's decreased, if you just look at the stomach, like there are a whole lot of different things going on. There's decreased gastric motility. There's also increased absorption, increased destruction of drugs, increased transit time in the small bowel, and so all this translates into unpredictability of what's going to happen to a given drug if you give it to this patient. This is every time I put this schematic up, I laugh and sort of shudder because I had this drawn, and I guess the person that was drawing it for me wasn't listening. Right before we sent it out for publication, I noticed that the person in the background here had extra parts that didn't belong on a woman. And so that almost went for publication. So we changed that quickly, and out it went. Okay, other considerations. The risk of teratogenicity is higher during the first trimester of pregnancy. This is when you need to be most careful about adding medications to patient's drug regimen. After 8 weeks, the baby's organs are complete, and so the risk to the fetus goes down substantially, and you can feel more comfortable using medications. And then teratogenic abnormalities depend on drug exposure, duration, and dose. And then there are specific drugs that you can use and specific drugs that you can't, and I'll go over those. This is absolutely true across the board. If you take care of if you're in a medical school and you indicate that you're willing to take care of pregnant people, every resident or resident's wife will come to you because increased ectopic activity is almost 100% seen in the atrium and ventricle throughout pregnancy. I mean, it's just a given that they're going to feel some ectopy. Women who have a previously diagnosed SVT or VT, like a normal heart VT, will have an increased risk for recurrence, and this is when patients who have had no previous history of arrhythmia will present for the first time. So ectopy and pregnancy go together. Diagnosis of arrhythmias in this population can be a challenge because the presentation, the palpitations, breathlessness, chest pain is funny, but a lot of people who are pregnant get indigestion and reflux, which can mimic cardiovascular chest pain. Syncope, we think of syncope as a really horrible problem and something that predicts a bad prognosis, but there are a couple reasons patients who are pregnant and have syncope that have no bad prognosis. One is that particularly as people get bigger, the baby can sit on their inferior vena cava, and all they need to do to not pass out is roll to their left side so they move the baby off the IVC. So there's nothing at all bad prognostically about that. Sudden death, fortunately, is very rare in pregnant patients, and we'll go over the different reasons for sudden death in this population. So, caveat here is that correct diagnosis of the arrhythmia is essential because of the adverse effects of drugs on the baby. And so there's no place in this patient population for empiric drug treatment. So whereas a patient with who's not pregnant may come and say, well, I'm having these extra beats and they're really bothersome, you might try an empiric beta blocker in that patient and see if it makes them feel better. You would not do that in the pregnant patient because you're exposing the baby to the beta blocker too. What can we use diagnostically? It's the same stuff you use in regular patients. Holter, event monitors, prescriptions for stat ECGs. We don't really need that anymore because of the event monitor. EP study, very rarely needed. And tilt table testing is acceptable, although also rarely needed. Vasovagal syncope kind of classic history is usually enough to treat these patients. If I have to pick between a Holter and an event monitor, I go with an event monitor. For those of you who don't use a whole lot of monitoring, the Holter is the one that patients wear for 24 to 48 hours. It is invariably the cure for whatever it is they're having, because it never shows up in the 20, they say, I wore it for 48 hours and it didn't happen. So that's always, that's always the way it is. So the event monitor, I like it's called a heart card or some variation thereof that they can carry in their purse, their pocketbook, pregnant people, men, if we're talking about a different group, in their wallet. Looks like a little credit card, and when they're having whatever the symptom is, they can put it over their heart, press a button, and it records an electrocardiogram. And so it shows you the symptoms and the EKG simultaneously. So if I have a choice, that's the one that I use. EKG, most of these patients, you can figure out what the problem is with either a simple electrocardiogram or an event monitor. If you cannot document anything using this, it is very unlikely that there is a life-threatening arrhythmia present. And then I quit at that point. If they can't show it to me, show me what the problem is with either an event monitor or an ECG, then we don't do any further. Particularly, we don't do any invasive evaluation at that point. The EKG during pregnancy is pretty typical. It shows a shift in the QRS axis to the left in the frontal plane with a small Q wave and an inverted T, and I'm going to show you an example. These are absolutely normal changes in the electrocardiogram and are probably related to the baby, coming up and pushing everything sideways and up in the thorax. This is a patient of mine many years ago, so no Q waves inferiorly, T waves sort of flat, but sort of normal looking. And then this is way into pregnancy, develops these little teeny Qs over here inferiorly, and then the T wave is inverted. This is a totally normal change for a pregnant person. So management of specific arrhythmias, document the etiology. Remember, we know drugs for people, then we don't know what it is we're treating because it's going to affect the baby as well. I usually get an echo just to make sure the heart function is totally normal. Generally speaking, it is, but every once in a while you get surprised. It's important to have an echocardiographer who understands the differences that they might see in a pregnant patient's echo because of all the volume overload. Reassurance for palpitations, if all they have are single PACs, PVCs, and they can live with it, reassurance is the best treatment. If they have a totally normal heart, chances that anything bad is going to happen during their pregnancy from a cardiovascular standpoint is very low. If they cannot live with their symptoms, beta blockers are the drug of choice in the patient who continues to be symptomatic. But and I'll go over which beta blockers. There are some beta blockers that are okay to use, and there's a beta blocker that you absolutely should not use. Now, we have I find it useful, rating of drugs that we use in pregnancy. The FDA puts out categories A through X. A would be a drug that has been in a controlled study showing no risk. There are zero 0, cardiovascular drugs who have a Category A designation. We don't generally do big clinical trials on pregnant people. Category B, no evidence of risk in humans. There are a few cardiovascular drugs, and I'll tell you what they are. The majority of our drugs in cardiology are Category C, which means that risk cannot be ruled out, but we've got a long historical use of these drugs, and our OB people are totally comfortable with them, and so these are drugs that we have no issue using because the risk has not been definitively shown. Category D, there is evidence of risk. You should, don't use them. D. In Category X, that's absolutely contraindicated in pregnancy. So if you just remember all drugs are Category C, it's easier to remember the exceptions because there are so few of them. The Category B is acebutolol in the beta blocker category and pindolol. Those are the only ones that are B. I sort of use pindolol if I have to use a beta blocker. And atenolol is the only Category D. So atenolol is the one you absolutely do not want to give your patient with palpitations. All the rest you can use if you like. The OB people are comfortable with most of these other beta blockers. Pindolol is a B, acebutolol is a B, atenolol is a D, don't use it. SVT, like as I implied a little bit earlier, the first event will happen during their pregnancy, or if they've had it before, it'll be more recurrent during their pregnancy. AV nodal reentrant tachycardia, WPW, which is AV reentrant tachycardia, AFib and flutter less frequently. Adenosine is the drug of choice to terminate the arrhythmia if vagal maneuvers fail. Adenosine is not going to hurt the baby. Remember, it's gone in 6 seconds. We don't think any of it even ever reaches fetal circulation. If they have recurrent SVT, if it's well tolerated or infrequent, forget it. They don't need to be treated with anything. Many of these patients say, well, I get it, but it goes away in 2 minutes, or yeah, I get it, I can stop it myself. That's fine. Just leave them so long as they have no hemodynamic issues. If I faint every time I get it, that's a bad sign, because if they're not perfusing their brain, they're not perfusing their baby. But if they feel fine, don't treat them. If you decide you have to, decision made to treat, the first choice would be AV nodal blockade, assuming no obvious pre-excitation. Antiarrhythmic drugs, I'll show you the list of them. These are the drugs you can use, and this is the order that I would use them. Sotalol is a Category B. It's the only antiarrhythmic drug that's Category B. Everything else is a C, and some are Ds and Xs. And quinidine, going back to my previous assertion, I think quinidine is a drug that has run out of its usefulness, but the OB people really like quinidine, and it's got a long, long history of use in pregnancy. So in this particular situation, quinidine would be okay, but I'd go with sotalol or flecainide first. All the calcium channel blockers are Category C, so you can use any calcium channel blocker that you prefer. And this is the list of antiarrhythmic drugs. Again, everything, if you can remember, everything's Category C, and then the exceptions are easier to remember. Lidocaine, which you wouldn't use it for a supraventricular arrhythmia, is a B. Amiodarone is a D, and sotalol is a B. So sotalol, if you have to use an antiarrhythmic drug, sotalol is usually my first choice. What about anticoagulation? Heparin is in the heparin-warfarin choice. Heparin is the drug. It's got a large molecular weight that prevents placental transfer, so it doesn't affect the baby. Warfarin, on the other hand, is associated with or can cause spontaneous abortion, CNS disease, including optic nerve atrophy, mental retardation, microcephaly, death, secondary to intracranial hemorrhage, and or an embryopathy if you don't have spontaneous abortion in about 40% of infants. And, so in that choice, it's a little bit tough. Luckily, most patients who are pregnant do not require anticoagulation. So what about cardiac arrest in pregnancy? I mean, this is changing as the patient population gets older. I mean, we're going to see, as mothers get older and older, we're eventually going to see some patients with sudden death that is associated with coronary artery disease. But the vast majority of patients who have sudden death from pregnancy have it from something that we don't usually think about in cardiology or in internal medicine. They have amniotic fluid embolism, eclampsia, drug toxicity, bad anesthesia, aortic dissection, PE, and hemorrhage from a OB complication. Those are the more common things when you have a cardiac arrest. There are some modifications to basic life support that you should be aware of if you become involved in resuscitation of a pregnant patient. Remember, I said the baby can sit on the inferior vena cava, especially later in pregnancy. And so it's important to relieve aortocaval compression. If the patient's flat on her back and has had sudden death, you want to manually push the baby off of the IVC, so to the left. And many people also it's helpful if you use try saying that 10 times, wedge-shaped cushions, pillows, or rescuer's thighs, overturned chairs, anything you can do here under this side of their back to turn them this way and keep them that way while you're doing CPR, to keep the baby over to the left and off of the inferior vena cava. It's funny, I had twins 15 years ago, almost 15 years ago to the day, and I had them sitting on my IVC frequently. And I remember I told one of the techs, I do pacemakers and ICDs mostly for a living, and I said, you know, if I say I need a chair, would you run a chair over, because I'm about to pass out because my babies are sitting on my inferior vena cava. I go, sure, yeah, I'll run you a chair over. So I said, John, I need a chair. And he goes, do you want the small cushioned one over there, or do you want this thing over? And I was like, just a chair, you know, and just moving, changing position for some of these patients, not in sudden death, obviously, but when the baby sits on your IVC, just changing your position makes a big difference. Okay, back to sudden death. Perform chest compressions higher on the sternum. I had, this is a schematic that I absolutely have to redo. It's so terrible. It's really ugly. But I had this drawn by the same person who drew the man with all the changes in pregnancy. This is a schematic of what I'm talking about. So they have here we have these chairs, sort of the backs scooted under the woman so that the baby goes this way, and so she's sort of turned up on her left side, and then he's performing CPR a little bit higher on the chest than you normally would. In terms of ACLS, there are no changes to the standard ACLS algorithms. That includes medications, intubation, defibrillation. Do everything that you would normally do. We used to think, well, don't use an amiodarone under any circumstances. It's a category D, but that's sort of silly, right? These people are dead, and if amiodarone helps you resuscitate them, you know, if they're dead, the baby's not going to do well. So I think you use whatever you need to use to recover the mother here, and then you worry about the amiodarone later. That said, defibrillation and cardioversion are absolutely necessary in sudden death, particularly if it's from VF, although remember all those other reasons that can cause sudden death in these patients. Defibrillation and cardioversion, there's no adverse effect to the mother or the baby with energy as high as 300 joules. We don't think that much of that energy reaches the baby. This is the most critical point. You have to get your OB people involved immediately. The decision, you proceed with a C-section within 5 minutes of the cardiac arrest. Now, I gave this talk to the OB people once because I thought, that's ridiculous. You can't get anything done in 5 minutes, right? They tell me if they are on the spot, if they get there, they can have a baby out in less than 5 minutes. So you get them there as fast as you can get them there. That has the highest chance of improving the outcome for the mother and the baby. Just a word on congenital long QT syndrome. A lot of these patients floating around, many of them now are at the age of and having babies. Some of them have defibrillators. That's fine. Defibrillators do not affect whether or not a patient should have become pregnant. But you should know that there's an increased risk of events in the postpartum period. So that you have to have these patients on beta blockers throughout their pregnancy and into the postpartum period, even if they had no symptoms during the pregnancy. And it's a mistake I see frequently. People, the patient's pregnant, they put them on beta blockers, they're very diligent about it, pregnancy ends, baby's fine, and they say, oh, phew, off with the beta blockers, and that's when the patient has a problem. So throughout the postpartum period, they still need to be treated. When do we hospitalize pregnant patients? I mean, you want to minimize putting people in the hospital for things that are unnecessary. Bad things happen in hospitals. So it's necessary, obviously, cardiac arrest, sustained VT, unstable VT. By that, I mean the patient had symptoms of syncope or reasons to think they're not perfusing their brain. Again, if they're not perfusing their brain, they're not perfusing their baby. Or if you want to start an antiarrhythmic drug, although I don't always start antiarrhythmic drugs as an inpatient, in pregnant patients I do. And that's because of the unpredictability of drug treatment with all the hormonal and volume changes that are going on. It is not necessary to hospitalize people for evaluation of palpitations or for well-tolerated supraventricular tachycardia that terminates with vagal maneuvers, even if it's new. Even if they have a new SVT, I don't put them in the hospital necessarily for that. This is a recent publication that I thought was interesting for those who are in primary care. This study came out about preeclampsia. Because of the unique cardiovascular metabolic stress, pregnancy provides an opportunity to estimate a woman's lifetime risk for cardiovascular disease, and specifically preeclampsia may be an early indicator of cardiovascular risk. This meta-analysis found that a history of preeclampsia doubles the risk of subsequent ischemic heart disease. And healthcare professionals who meet women for the first time should take a careful history of pregnancy. It's not absolute, it just gives you some more information on the patient. All right, to wind up, I just wanted to mention some other medicines that we're going to be seeing that pregnant people will be taking. Clopidogrel, category B, so it's okay. Tylenol is okay. Ibutylide is C, dopamine is a C, nitroglycerin C, and nasiratide is C. So all of these drugs, you will see some of these patients taking them, and they're okay. ACE inhibitors are a no. If somebody's thinking about being pregnant, they should not be on an ACE inhibitor. If you find them pregnant and they're on an ACE inhibitor, you should stop it. They're category C for the first trimester and D during the second and third. That's walking a fine line there to have them on category C until the end of their first trimester. Most of the time, we don't even know when that is. So if you have a patient who's thinking they want to get pregnant, just don't use ACE inhibitors. If you meet them for the first time and they're on it, stop it. Let's see. Aspirin, should not take aspirin during pregnancy. There's a FDA warning that using it in the last trimester of pregnancy may be associated with Reye's syndrome. We just avoid aspirin totally during pregnancy. Metformin, we're going to see more and more people taking this medicine in pregnancy, category B. It's fine. Statins, absolutely not. These are category X. They're not supposed to be taken by pregnant women. They cause birth defects. So again, anticipating pregnancy, off the statin. You find somebody taking a statin who's pregnant, stop it. And enoxaparin, this is category B. Fine to use it if you have to. It has an advantage over heparin. It doesn't contribute to maternal osteoporosis. So to wind up, correct diagnosis of the arrhythmia is vital. You have to decide which is more dangerous to the mother and the baby, the problem or the treatment. And generally, you're thinking most of these treatments are okay for the mom, so this is where you really have to think, is this treatment okay for the baby? Choose drugs with the most historical use. Your OB people will be really helpful to you in that. You say, do you guys use it? Oh yeah, we use it all the time, no problem. You feel very comfortable using it. If you don't have an OB person who can tell you that, then choose the ones that are category B or C. And obviously, use the least number and the lowest dose that is effective. Sometimes non-pharmacologic treatment is unavoidable. For example, people now with defibrillators and pacemakers, that does not change their ability to become pregnant. Cardioversion and defibrillation are safe, particularly in sudden death, you have to do it. And in a patient with cardiac arrest, remember that it's most likely not from coronary artery disease. You have to think about what those other reasons are.